You know, usually when we think about like aesthetic injections, the image that pops to mind is, well, a very specific piece of real estate.
Right, yeah, like foreheads, lips, maybe cheeks.
Exactly. It's super localized. You put a drop of filler into a wrinkle, it plumps up, and I mean, that's basically the end of the story.
Yeah, it feels predictable. And that's mostly because facial tissue is relatively static. You know,
Yeah.
you're almost just, well, spackling a tiny dent in a piece of drywall. The material generally just stays right where you put it.
Right. But then you take those exact same syringes and you move them below the belt into the whole world of vaginal rejuvenation.
Oh, yeah, and that changes everything.
It really does,
Yeah.
because suddenly that predictable spackle turns into something completely wild. We are talking about cosmetic fillers physically migrating through tissue planes to mimic like anatomical structures that absolutely should not be there.
Yeah, it's a completely different environment.
And we're talking about bizarre, life-threatening complications. But on the flip side, we are also looking at a brand new, like, groundbreaking clinical trial. One that might take these exact same injectables and shift the entire medical paradigm from surgical reconstruction over to natural tissue regeneration.
The stakes could not be higher. I mean, when you're dealing with this specific anatomy, you are navigating incredibly complex vascular systems.
And high friction, right.
Exactly, high-friction environments. It fundamentally changes the behavior of every single substance you introduce down there.
Well, welcome to this deep dive. Today, we are opening up a massive stack of medical literature for you. We've got clinical case reports, we've got the official guidelines from the American College of Obstetricians and Gynecologists, FDA safety communications, and even blueprints for a brand new clinical trial.
It's a lot of ground to cover.
It is, yeah. And our mission today is to explore a highly targeted, rapidly growing, and frankly incredibly controversial medical question, which is, can poly-L-lactic acid, or PLA, or calcium hydroxyapatite biostimulators ever be safely injected for anterior vaginal wall augmentation instead of the current standard, which is hyaluronic acid?
It is a question that sits right at the bleeding edge,
Right.
where cosmetic trends just smash into functional reconstructive medicine.
Okay, let's unpack this. Because to understand where we are going with these biostimulators, we kind of have to look at the sheer explosion of this industry first.
Oh, absolutely.
People are clearly looking for non-surgical options. So based on the data we're looking at, what kind of growth are we actually seeing here?
I mean, it is a boom, undeniably. If we just look at the raw numbers, the interest is skyrocketing.
Like how much?
Well, we saw labiaplasty rates jump over 50% between just 2014 and 2018 alone.
Wow.
Yeah, and then there was another 36% spike
Okay.
just from 2020 to 2021.
That is massive. But, when I was reading through the official guidelines from the major medical bodies, there seems to be this huge disconnect, like a gap between what consumers are asking for and what doctors are officially, recommending.
There is a deep tension there, yeah. And we have to look at this impartially, right? The established medical community's stance is cautious. Honestly, it's bordering on restrictive.
Right, because of the ACOG warnings.
Exactly. The American College of Obstetricians and Gynecologists, or ACOG, they represent over 60,000 women's health physicians. And alongside the FDA, they have issued very explicit warnings.
Just flat out saying don't do it.
Pretty much. They state clearly that a lot of these female genital cosmetic procedures, particularly those using energy-based devices like lasers or radiofrequency for quote-unquote vaginal rejuvenation, they are just not medically indicated.
Yeah, I saw the FDA even points out they haven't cleared any energy-based devices for treating symptoms related to like menopause or incontinence or sexual function.
Right. The overarching stance from these regulatory bodies is just that the efficacy of these cosmetic procedures hasn't been proven at all.
They just don't have the data.
Exactly. They lack high-quality, randomized, controlled safety data. And furthermore, ACOG warns that these procedures are heavily driven by aggressive direct-to-consumer marketing.
Oh, for sure.
Yeah, rather than true medical necessity. And they bring substantial risks, like burns, scarring, chronic pain, altered sensation.
So keeping that official guidance in mind, we still have this reality where patients are seeking out these options, right? Like they want the volume loss or the laxity addressed, but they want to avoid the scalpel at literally all costs.
Right. Nobody wants surgery if they can avoid it.
Exactly. And the go-to standard for that, even though it's technically off-label, has been hyaluronic acid, or HA.
Yeah, which makes sense from a cosmetic standpoint.
Right, because for anyone familiar with facial aesthetics, HA is like the most widely used filler out there. But when you inject it into the external genitalia, the pharmacokinetics change drastically, don't they?
They absolutely do. For an audience that tracks aesthetic medicine, you likely know HA is hydrophilic.
Meaning it loves water.
Exactly. It loves water. It draws in moisture to take up space and create volume. But the external female genitalia, like the labia majora, they are subject to entirely different physical forces than, say, a cheekbone.
Oh, yeah. Totally different.
You are dealing with constant friction, movement, and pressure from just, walking, sitting, exercising.
Which brings me to that case study. I was reading that report from Remedy Publications about a woman who went in for this exact procedure, and the result was, well, frankly, it was shocking.
Yeah, it's an incredible visual of what happens when a cohesive gel is just subjected to the kinetic energy of daily movement.
So what actually happened to her?
Well, this was a 43-year-old woman. She went to an aesthetic clinic for labia majora augmentation. She received 12 milliliters total of HA, so that's 6 on each side.
Okay, sounds standard.
Right. But 3 months later, she discovers these bilateral bulging masses. She goes in for an evaluation, and the doctors find that the HA had physically migrated away from the injection site.
Oh my God.
Yeah, it migrated and coalesced to form these bilateral lumps that literally mimicked, and this is a direct quote from the medical report, vulvar testicles.
That is horrifying. So the friction just pushed the filler into entirely new anatomical pockets.
Pretty much. It doesn't always stay where you put it. But as bizarre and, distressing as that kind of aesthetic migration is, it is actually the least of our worries when it comes to HA in this region.
Yeah, okay, let's talk about the darker reality here. Because there was a massive red flag in the review from the Korean Journal of Legal Medicine.
Yeah, that review looked really closely at the severe complications of genital aesthetic injections. And they found 14 reported cases of pulmonary embolism following these procedures.
14.
14. And 11 of those cases involved injections specifically into the vaginal wall. 2 of them involved HA specifically.
Wait, how does that actually happen? Like, how does filler in the vaginal wall end up destroying the lungs?
Right. It seems like quite a jump. To understand why this happens, we have to look at the underlying anatomy. The vaginal wall is surrounded by this incredibly dense, complex venous plexus.
Like a huge web of veins.
Exactly. A thick interwoven network of blood vessels. If a needle accidentally pierces one of those veins during the procedure and the injector pushes the HA filler directly into the bloodstream, it doesn't just sit locally.
Because it's a vein.
Right. The entire job of the venous system is to carry blood back to the heart, which then pumps it directly into the lungs to get oxygenated.
So the filler travels that exact same superhighway.
It does. The gel travels through the inferior vena cava, pushes through the right side of the heart, and is literally pumped into the pulmonary arteries in the lungs.
Oh, wow.
And as those arteries branch out and get smaller and smaller, that gel-like filler eventually gets wedged. It completely blocks blood flow to the lung tissue.
So that's the pulmonary embolism.
Exactly. The lung tissue dies, and it is potentially fatal.
It sounds like injecting HA into this highly vascular area is like playing anatomical roulette. I mean, if it hits a vein, it travels straight to the lungs.
It's a huge risk.
So if HA is this dangerous and prone to giving you migrating vulvar lumps, why on earth are clinics even offering it for things like G-spot amplification or anterior wall filling?
Primarily because it's so accessible. And it's what practitioners are already trained to use on the face. But crucially, in the minds of a lot of injectors, HA comes with a built-in safety net.
The undo button.
Yes, exactly. If you inject HA and you cause a local vascular occlusion, meaning you block a blood vessel and the local tissue starts turning white and dying, you can inject an enzyme called hyaluronidase.
Right, which acts like an undo button.
Yes. Hyaluronidase literally dissolves the hyaluronic acid block. It restores blood flow and saves the tissue.
Okay, I see.
But because of the severe systemic risks we just discussed, like the migration and the embolism risk, researchers and aesthetic doctors are urgently looking for alternatives.
They want something safer.
Right, so they are turning toward bio-stimulators.
Yeah.
Specifically, calcium hydroxyapatite, or CaHA, and poly-L-lactic acid, or PLLA.
Which opens up a massive question. Because if HA has an undo button but still causes pulmonary embolisms, what happens if you inject something that doesn't have an undo button?
And that is the terrifying part.
Yeah, because we need to understand the unique dangers of these biostimulators before we even look at their benefits.
What's fascinating here is the fundamental difference in their physical structures. HA is a smooth, cohesive gel, right?
Right.
But CaHA and PLLA are particulate fillers, They are made of tiny, solid, microscopic spheres or particles that are just suspended in a carrier gel or sterile water.
And there's no enzyme to dissolve them.
None. Absolutely zero. If you accidentally inject a particulate filler into a blood vessel and cause an occlusion, you cannot melt it away.
Oh my God.
The Journal of Clinical and Aesthetic Dermatology actually outlines the grueling emergency protocol for this exact nightmare scenario.
So what do they even do?
Because you can't dissolve the blockage, your only hope is to force the surrounding blood vessels to dilate as wide as possible, trying to basically force blood around the blockage to keep the tissue alive.
And reading through this protocol and the stack of sources we have, it is intense. Like, they are applying 2% nitroglycerin paste directly to the skin to force the vessels open.
Right.
They are giving the patient high-dose oral corticosteroids to shut down the swelling, aspirin to stop blood clots from forming around the blockage. They even recommend hyperbaric oxygen therapy to physically force oxygen deep into the starving tissues.
And perhaps most surprisingly to some people, they prescribe sildenafil, which is commonly known as Viagra.
Yes, I was going to bring that up. Using Viagra to save dying vaginal tissue from a filler injection sounds like straight-up science fiction. How does that actually work?
It does sound crazy, but it makes perfect pharmacological sense when you break it down. Blood vessels have these chemical systems that control how wide or narrow they are.
Like brakes on a car.
Exactly. Think of it like chemical brakes.
Hmm.
Sildenafil inhibits an enzyme called PDE5. And by stopping PDE5, it increases the levels of another molecule called cyclic GMP in the body.
Okay, so what does that do?
Essentially, it takes the foot off the chemical brakes. It causes the smooth muscle and the vascular walls to just relax completely. The blood vessels dilate wide open, ideally allowing enough blood to squeeze past that particular blockage and save the tissue from necrosis, permanent tissue death.
Wait, I have to push back here.
Sure.
If a particulate filler like CaHA or PLLA hits a blood vessel and we literally can't dissolve it, and we have to resort to hyperbaric chambers and Viagra just to hope the tissue doesn't rot away, isn't that vastly more terrifying than HA?
It is a very daunting protocol.
Right. So why would any doctor ever inject these into the anterior vaginal wall where that venous plexus is so unbelievably dense?
This raises an incredibly important question, and it's the exact tension medical science is wrestling with right now. The answer really lies in what these particulate fillers do once they are safely in the tissue and how they behave compared to HA's tendency to just migrate everywhere.
Okay, so let's look at calcium hydroxyapatite, or CaHA, first. Because despite everything we just said about the irreversibility of a blockage, CaHA is actually the only filler we are discussing today that has specific FDA approval for anterior wall periurethral injection.
Yes, specifically a product called coaptite. It was actually approved way back in 2005.
So what is it exactly?
CaHA is essentially synthetic bone material. It's calcium and phosphate. It consists of these tiny, hard, spherical particles, about 75 to 125 microns in diameter.
Wow, synthetic bone.
Yeah, but we have to be clear here. It is not approved for cosmetic plumping.
Right.
It is approved to be injected periurethrally, meaning into the tissues immediately surrounding the urethra, near the anterior vaginal wall, strictly to treat stress urinary incontinence caused by intrinsic sphincter deficiency.
Basically, the sphincter is weak, so you inject this synthetic bone material around it to bulk it up. It physically pinches the urethra shut so urine doesn't leak when you cough or sneeze.
Exactly. That's it. It's a localized bulking agent. And while the American Society of Plastic Surgeons notes that some providers use EAH off-label for cosmetic labia puffs.
Which sounds terrifying given the synthetic bone part.
It does. But when we look at its approved use in the anterior wall, the complication profile is severe.
Yeah, the warnings in the official instructions for coaptite are intense. It states that improper injection technique can lead to tissue dissection. But how does it actually cause the tissue erosion that the FDA warns about?
It basically comes down to friction. Remember, these are hard microscopic particles of synthetic bone. When you inject them into a highly mobile, high-friction area like the vaginal wall, it can act almost like internal sandpaper.
Oh, wow. Internal sandpaper.
Yeah. Over time, the constant rubbing and pressure can cause those hard particles to literally erode right through the delicate mucosal tissue. And that requires corrective surgery to fix.
That sounds awful.
It is. And on top of that, if the bulking agent is placed poorly, it can elevate the bladder wall, which can physically kink and obstruct the ureters, the tube carrying urine from the kidneys.
And if we look at the data from the journal Gynecologia I plus Nic 2, they note that while SAFA helps with the incontinence, it can cause granuloma formations.
Right.
That's essentially where the body builds a hard, fibrous wall around the foreign particles because it just can't break them down, right?
Correct. The body just encapsulates what it can't eliminate.
Plus, they explicitly note it offers absolutely zero improvement for sexual dysfunction.
Not at all.
So we are basically just trading one set of nightmares for another. I mean, we trade the migrating lumps and pulmonary embolism risk of HA for a surgical nightmare of internal sandpaper, tissue erosion, and bladder obstruction with a CAS.
Which brings us to the real bleeding edge of this field. Because if HA is prone to migration and fatal embolisms, and KHA risks severe tissue erosion because of its density,
Right.
is there any biostimulator that can aptly safely treat anterior wall issues without destroying the tissue?
And that leads us perfectly to poly-L-lactic acid, or PLLA. This is where we shift from looking at the flaws of CAS treatments to a brand new, completely paradigm-shifting clinical trial.
Yeah, if we connect this to the bigger picture, we first have to understand what PLLA actually is. It's commonly known by the brand name Sculptra.
Okay.
But unlike HA, which just takes up space and holds water like a sponge, and unlike KHA, which acts like a physical buttress or a rigid bulking agent, PLLA is a true biostimulator.
So explain how it works mechanically in the tissue, because it's fundamentally different from just plumping something up.
Totally different. When PLLA particles are injected, they don't provide immediate volume. Instead, the body recognizes this poly-L-lactic acid as a foreign material, but crucially a biocompatible one. It triggers a very specific, controlled, subclinical inflammatory response. The immune system sends macrophages to the area. Think of them as a cellular cleanup crew.
Right.
And those macrophages then activate fibroblasts.
And fibroblasts are essentially the body's collagen factories.
Precisely. Over the course of several months, as the PLLA particles slowly biodegrade and are just fully absorbed by the body, those fibroblasts lay down brand new, native type 1 collagen.
So it's building real tissue.
Yes. It gradually thickens and strengthens the structural matrix of the tissue itself. You aren't leaving a permanent filler behind. You are forcing the body to rebuild its own internal scaffolding.
Here's where it gets really interesting. Because they aren't just using this to cosmetically smooth out wrinkles on the labia. We have the blueprint for a highly anticipated clinical trial right here, NCT 07544667.
Yes, this trial is fascinating.
They're taking PLLA and using it to treat pelvic organ prolapse, specifically stage 2 cystosol. What does that actually mean for the patient experiencing it?
So, for context, a cystocele is when the supportive tissues between a woman's bladder and vagina severely weaken and stretch. This allows the bladder to physically bulge or prolapse down into the anterior vaginal wall. And a lot of people deal with this, right? Millions of women suffer from this. And the physical reality of living with a stage 2 cystosole means dealing with constant pelvic pressure, like a literal sensation of a bulge sitting in the vaginal canal. It causes urinary issues and a massive negative impact on their daily quality of life and sexual function.
And current treatments are basically, what? Physical therapy, which has limits.
Right.
Or a plastic pessary insert to physically hold things up, or just full-on surgery. But surgery leaves scar tissue, it alters the natural topography of the vagina, and it can severely damage sexual function.
That is exactly what makes this trial so revolutionary.
Yeah.
They're investigating whether we can use a biostimulator to treat an anatomical structural failure, bypassing the scalpel entirely.
So how are they actually doing this? From the trial blueprints, they are taking women with stage 2 cystosol, and they are injecting the anterior ventral vaginal wall with PLLA, but they're diluting it heavily.
Very heavily, yeah.
It says 8 milliliters of sterile water and 1 milliliter of lidocaine. They do this once a month for 3 months, and they're comparing it against a control group getting just sterile water injections.
The heavy dilution is the absolute key to making this work safely. By adding that much sterile water, they're ensuring the microscopic PLLA particles are widely dispersed throughout the tissue.
So they don't clump up.
Exactly. It prevents them from clumping together and forming those hard granulomas we see with other fillers. They want an even, gradual wash of collagen stimulation across the entire weakened anterior wall, not just localized hard lumps.
And they're tracking safety rigorously. The blueprint says they're using the Clavian-Dindo classification system to measure every single adverse event over a 9-month period. Can you break down what that system is for us?
Yeah, the Clavian-Dindo system is a highly standardized, universal way for doctors to grade complications from surgical or medical procedures. It ranges from grade 1, which might be a super minor deviation needing no real treatment,
Okay.
all the way to grade 5, which is death.
Wow. Okay.
So by using this system, the researchers are mapping out exactly how safe this PLLA injection is compared to the established risks of traditional prolapse surgery. They're also measuring the physical descent of the prolapse itself and tracking patient-reported pelvic floor distress and sexual function.
It is a meticulously designed approach to see if PLLA can restore the actual tensile strength of the vaginal tissue while preserving sensation and blood flow. I want to use an analogy here because the contrast between these treatments is wild to me.
Go for it.
Right now, if a wall in your house is collapsing, the current filler methods like HA or CaHA, they're basically just trying to stuff things behind the drywall to prop it up. HA acts like a water balloon that might randomly roll away into another room or pop into a pipe and block it entirely.
That's the migration and embolism risk, yeah.
Right, and CaHA is like shoving a hard brick back there that might eventually just rub a hole right through the drywall.
That's a highly accurate way to visualize the physical properties and the risks we've discussed.
But this PLLA trial, I mean, if this works, it's not stuffing a pillow or a brick. It's like planting seeds inside the wall that grow a dense network of strong, flexible vines that actually become the new structural fabric of the wall itself.
That's exactly it.
The wall just holds itself up. We are moving from surgical reconstruction to natural tissue regeneration.
That is the exact promise of regenerative aesthetics moving into functional medicine.
Oh.
By safely utilizing the body's own localized inflammatory response, you are potentially bypassing the need for a scalpel, you're avoiding the creation of rigid scar tissue, and you're allowing the prolapse to resolve organically.
It's incredible. So let's bring this all together for you because we've covered a massive amount of medical ground today. The core question we started with, can CaHA or PLLA replace HA for anterior wall augmentation?
The answer is yes, but with intense caveats and a very steep learning curve for the medical community.
Right. We know hyaluronic acid is incredibly popular, and it's the gold standard for the face. But below the belt, it poses absolutely terrifying risks. It can migrate into lumps that mimic anatomy, and because of the dense venous plexus in the vaginal wall, it carries the severe risk of traveling to the lungs and causing a fatal pulmonary embolism.
Then we have calcium hydroxyapatite. It is FDA approved for periurethral injection for incontinence, but it brings the threat of severe tissue erosion, dissection, and urinary obstruction, mostly because the particles act like internal sandpaper against the mucosal tissue.
And finally, poly-L-lactic acid. It requires a terrifying emergency protocol involving Viagra and hyperbaric chambers if it accidentally hits a blood vessel. But if injected correctly and evenly into the tissue, it represents the bleeding edge of regenerative medicine.
It really does.
It offers the hope of actually treating structural conditions like anterior wall prolapse by forcing the body to rebuild its own natural collagen scaffolding.
It's a perfect encapsulation of where this entire field is right now. We are taking tools that were developed for vanity, and we're attempting to re-engineer them for profound functional healing. But this raises an important question, something for you to consider as these clinical trials progress.
What's on your mind?
If biostimulators like PLLA actually prove successful in regenerating the structural integrity of the pelvic floor, like if we can truly grow back the support network of the anterior wall using just a syringe, could we eventually see a future where the line between cosmetic gynecology and reconstructive surgery just disappears entirely?
Wow.
Yeah. Could the scalpel eventually be completely replaced by the syringe when it comes to treating the anatomical realities of aging?
That is a fascinating thought, going from just, speckling a tiny wrinkle on a forehead to literally regrowing the structural foundation of the human body, all from the exact same syringe. Thank you so much for joining us on this deep dive. Keep learning, keep questioning, and we will catch you next time.